So we wanted to take this opportunity to discuss ADLs for the administrative team. We spend often a lot of time teaching CNAs and nurses and MDS coordinators about how to code it on the MDS and how to calculate it, but not always making sure that the administrative team, who are often questioned about it when looking at your RUG analysis, understand how this all works. So here's a spoiler alert. Every single RUG category under both Medicare and Medicaid is impacted by ADL scores. So do you know how your team manages yours? What's the cost of an ADL point? So when you're looking at RUs, RUB and RUC, there's no difference in dollar amounts under the Medicare system for that. So if you got an RUB, RUC, you're going to get paid the same. So often people don't dedicate the time in looking for the opportunity to move somebody who's sitting at the 1 point cusp of an RUB to an RUC. But an RUB and RUA have a very significant payer difference. And I use Ludlow as an example for their rates. And an RUB pays approximately $745 a day, and an RUA $623 a day if we want to round. It's $122 a day difference. And as a sidebar, what happens if an audit drops that RU to an RV, an RH, or an RM, and you didn't maximize that ADL because you weren't concerned about it when it was a B and a C? Well, under an RV, RH, and RM, you can see the dollar amounts, anywhere from $4 to $86 a day for an RVC. An RHC, going to a B to an A can be anywhere from $56 to $59 a day difference, and an RMC to a B to an A can be anywhere from $30 to $82 a day. So across the bottom we have C-level ADLs are at 11 plus. So whenever you're seeing people at an 11, at a 10, they're at a B, you're trying to get them up into the next level, it's a C. All right, and when you see people at an A level, when they're at a 5, going up 1 point is going to get them into the B level. And again, you can see a sample of how those dollar amounts change just by getting that. So if you see a score of 5 or 10 when you're in your Medicare meeting, stop the meeting, okay? It means you're 1 point from the next rehab RUG. Would a different ARD capture that point? Is the documentation accurate? Is bed mobility or transfers coded as 4 2s? Because that's not really clinically appropriate to be moving somebody total with one person. Is eating coded as 8-8, particularly on the 11 to 7 shift, meaning it didn't occur? Did we look at the nurse's notes and rehab documentation and not just the ADL flow sheets? And know that under case mix, IV fluid gets you 3 ADL points. So did we pick an ARD that captured that? Those are your red flags when you're at a 5 or a 10. If you get an ADL score of 0, this means that the person's totally independent in all 4 of their late loss ADLs. You really need to look, is this a 5 or a 14-day MDS? What did we bring them in under rehab? Are they getting RU levels of rehab, and how are we justifying that with a 0 ADL? Is the ADL documentation right? Is bed mobility or transfer coded as 4-2? Is eating coded as 8-8s? What is rehab working on? And what was the prior level of function, and what are our goals now? So yes, you may still get a 0. Yes, you may get a 5. Yes, you may get a 10, but you need to stop and question those things before we move any further. Not only because of reimbursement, because of the integrity of your data as well. So late loss ADLs, there's only 4 that count. Bed mobility, transfer, toileting, and eating. So when you're asking your team about scores, or if we're asking you about your scores, we don't accept any responses that don't address those areas of performance or assistance. All right, and so to the right, you can see what's included when we're talking about bed mobility. It's not just about laying to how they go from a laying position to a sitting position, but how they turn side to side, how they position their body when they're in bed by themselves, or if they sleep in a recliner chair because they have COPD or some other sort of reason, how they move in that chair. All right, so we don't code an 8-8 because they sleep in a recliner. We address bed mobility even though they're in the recliner. Transfer, how the resident moves between surfaces to or from the bed, the chair, the wheelchair, or into a standing position. Now, you don't count bathing or toileting transfers in this, but think about this. A lot of times people respond to you and say, oh, they're walkie-talkies, they're up walking around all over. Transfer coding includes how they got to the standing position. All right, so we need to look at that and make sure. So just because you see somebody up walking around doesn't mean they didn't code very high on their transfer status, getting from perhaps a lower chair to a standing position. Eating, how the resident eats and drinks regardless of their skill. We don't include any eating or drinking that happens during the medication passes, but we look at tube feedings, IV fluids, all of those things get calculated into this, particularly for case mix. And we want to make sure that on the 11 to 7 shift, they understand that just because a meal isn't delivered doesn't mean that a patient shouldn't be and wasn't offered fluids and assisted with an eating task that includes drinking. And then toilet use, how the resident uses the toilet room, the commode, the bedpan, or urinal, how they transfer on and off the toilet, how they clean themselves after they've eliminated, if they change their own pads, how they manage their ostomy or catheter, and adjust their clothing. The only thing we don't count is how we empty the bedpan, the urinal, the commode, or a catheter. So there are lots of little pieces of this and how it gets coded. So again, we want to make sure that we are not so arrogant to think that just because someone gives us a very superficial answer, or that we say, oh, they're up walking around, it's the type of patients we get, that we haven't gone and considered all of these different tasks and subtasks on all of the shifts. So again, this is just reiterating bed mobility, lying to sitting, side to side, positioning themselves. Transfer to and from bed, wheelchair, or standing position. Toileting, all of those things. Eating means eats and drinks. So to calculate the ADL score, if you are doing this for Medicare or the 48 grouper, then you're using the RUG-4. So in Vermont and all Medicare people, you're using this coding system that has ADLs ranging from 0 to 16. If the first three, bed mobility, transfers, and toileting, all use this top key, while eating uses a separate key. So if the patient, which is self-performance, is coded as a dash, we don't know, a 0, 1, 7, meaning it happened less than 3 times, or 8 didn't occur at all, any amount of support, you're going to get 0 points. Doesn't matter. So if the patient did any of this, and even if we had 2 people help them on one day, you're still going to get 0 points. If somebody is 2, limited assist with bed mobility, transfer, and toileting, doesn't matter how many people assist them, you're only going to get 1 point. So if you have somebody as a 2 and coded as a 3 for 2 people helping them at any point, you're still only getting 1 point. It's not until you rise to the level of extensive assist, which is a 3, that then it matters how many people we use. So if you're using 0, 1, or 2, meaning 1 person assist, you're going to get 2 points. If somebody's a total and they're using 1 person assist, they're going to get 3 points. When you get up to whether they're extensive or total and they use 2 people, which is a 3, you get 4 points. All right, so whether somebody is limited assist, a 2, doesn't matter how many people help, you're getting 1 point. Extensive assist, up to assist of 1, you're going to get 2 points. Total dependence with 1 person, so this is your bed mobility, when you code it as a 4-2, which is not clinically appropriate, transfers coded as a 4-2, not clinically appropriate, you're getting 3 points. If you were to provide the clinical appropriateness of 2 people to move somebody appropriately in bed and or transfer them, you're going to get that 1 additional point, because it's going to be 4 now. So you need to pay attention to those codings. It's not just getting 100% compliance with the documentation, but it's making sure that it's accurate and that we can rely on it for how we develop care plans, as well as how we get paid for providing that care. And then for eating, you can get anywhere from 0 to 4 points for eating. And so this is it didn't happen 3 times, it didn't occur at all, a limited assist, supervision, any of those, no matter how much support, you're going to get 0. When you start to give 1 person or 2 people for eating, not sure when we do that, but it's assist of 2. When we get to 3 or 4, meaning extensive or total, and we only use nobody, supervision, this code would never happen. All right, then you're going to be a 2. Somebody's extensive assist and uses 1 or 2 people, you're going to get 3. 4, a total dependent using 1 or 2 people, you're going to get 4. Okay, so it doesn't matter really the number of people you use. And just know that this 3 or 4 and this code would never happen. Can't happen because this has to happen 3 times. And if it happens 3 times, then you had to have had somebody assist them if they were extensive or total. So that doesn't even make sense for them to put those codes in there. So it's not something you would ever get. So just remember that this is Medicare and Vermont case mix using this tool, and the ADL scores are 0 to 16. And under this system, you do not get 3 ADL points because they're on IV meds or get IV or tube feeding. This calculation is used for all the other case mix states. So the New Hampshire 34, the Maine 44, and the New York 53 all use this system, and where again it's still bed mobility, transfer, and toileting separate from eating. And a 0, 1, or 7 with any amount of staff helping is going to give you 1 point. Limited assist with any amount of staff is going to give you 3 points. Limited or extensive assist with 1 person assist is going to give you 4 points. And then you have extensive, total, or didn't occur, and you're going to get 5 points for that. So look at this, coding somebody as not moving in bed, not being having transfers, and not being toileted for 7 days gets you the most ADL points. So that's how these things are kind of off balance, because we don't keep people in bed anymore. We get everybody up every day pretty much. So when you have these codes in here, it's actually an incentive for you to not transfer, to not get somebody out of bed. You're going to get a higher ADL score. But of course, then you're also going to have higher incidence of wounds and pain and, you know, all kinds of other issues going on. So of course, it's not recommended. I'm just pointing out that inaccuracy in this system. If the person's on IV, you're going to get 3 ADL points. In Section K, you code they're on IV fluids. And regardless of what the CNA puts in Section G, regardless of what the MDS person codes, you're automatically going to get 3 ADL points if they're on IV fluids. If they have a tube feeding and their calories are 51% or more, then they're going to get an ADL score of 3. Okay. If the tube feeding's checked and the calories are 26 to 50% and they get the 501 cc's, they're going to get an ADL score of 3. So you don't have to do any of this. But if indeed there's no IV fluids, there's no tube feeding, then this is the way eating is calculated, a 0, 1, or 7 for the resident self-performance with, you're going to get 1 point. Doesn't matter how many people are doing this for eating, where in the Medicare one it does. Limited assist, you're going to get 2 points. Once you get to extensive, total, or didn't occur, once again, kind of inaccuracy in how we do things, you're going to get 3 points. And then you add up all of those, and remember again, this is not used in Medicare. So that hopefully helps you understand a little bit more about the ADLs and how they can be used and the types of questions you should ask and when you should be alerted to stop any sort of discussions or meetings to further investigate your documentation.